Hello, ladies and gentlemen. This will be an update to a lecture that I recorded about 4.5 years ago on managing the patient with HIV. Now, it's an ongoing struggle trying to keep up with all these new changes that go on. A lot of you will comment and say that, well, this isn't what it used to be, and that doesn't mean I'm going to update the lecture because sometimes the changes are just minimal, and you won't need to know really tiny nuances in some of the changes that happen. However, some of the changes that have gone on in the last 4 years as far as how we manage patients with HIV have been really drastic, substantial changes to some of the fundamentals. And we're going to talk about that. And so this is going to be an updated talk on how we manage patients with HIV. So I hope this will help you because some of these changes will come up on the test. If a change happened 6 months ago, you're probably not going to need to know that for the USMLE. But if the change happened 2, 3, 4 years ago or more, then you need to know, and that's why I'm updating this lecture. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below in the description of the video or on the I button on the upper right hand corner up here, and it should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. If you subscribe, you'll also have access to some of my premium videos in which I go over case reviews, how to formulate differential diagnosis, and a treatment plan. And that will be very useful for you as you approach cases where you don't have multiple choices, particularly the clinical case scenarios that come up on step 3 of the USMLE. Thank you very much in advance for your support. So this is the adult HIV prevalence throughout the world. So I put up here HIV/AIDS throughout the world, but really this is HIV throughout the world. Some of these patients probably do have AIDS though. But you can see that HIV/AIDS is a big problem in Africa. And I'm sure you know this, it's in popular culture all over the place, but it's a big problem in Africa. You can see though that the United States has a relatively higher prevalence than Canada, which is very culturally similar to us, and mainland Europe. And I believe that has something to do with the healthcare system. We do not have a very good healthcare system here. The healthcare system here is good if you have money, but if you are poor, it's not good. And so we have these disparities, and as we're going to see, those disparities lend themselves to a higher prevalence in certain populations compared to others. So other problem areas, Russia, Ukraine, Southeast Asia, India. I know a lot of my viewers are from India, so you can probably chime in on that. Now, if you look at the United States on a county-by-county level, you will see that there are 2 types of areas that have a higher prevalence. First, as you can imagine, the cities. The urban areas have a higher prevalence. So here, where I live, in the Minneapolis area, if you just go from where I live down 30 miles into Minneapolis, you see a big stark change. So where I live, very low prevalence. It's in this bright yellow area. But if you go into Minneapolis, where I spend a lot of my practice, you have a very high prevalence. And that holds true for a lot of the inner city areas. So Minneapolis, Milwaukee, Detroit, Chicago, even going out here towards the Denver area, San Francisco, Seattle, higher prevalence. And that stands to reason because urban areas tend to be poorer. Now, I'd like to look at West Virginia out here, sort of southeastern Ohio, because those tend to be poorer, but they're also very white, and see how that compares. But they don't have data available, unfortunately. Now, another area that is a problem area for HIV is the Deep South, including Florida. Florida doesn't like to think of themselves as a southern state sometimes, but yes. So you look at Florida, Mississippi, Alabama, Georgia, Louisiana, it's a problem there as well. And that actually even cuts across urban-rural divides. So even in rural areas there, you see a problem. If any of my viewers, by the way, are from upstate New York, I'd like to know what's going on, because these are not densely populated areas. You would expect them to be more like Maine, or rural Wisconsin, or rural Minnesota, or Wyoming. What's going on with New York here? Rural New York is affected like the South. I don't know what that is. It's a relatively affluent area as far as I know. So if any of you guys are from that area, please let me know what's going on there. I wasn't able to find anything about it. Okay, so cutting across racial lines here, you see that the African American population here in the United States makes up a higher proportion of HIV patients compared to their proportion in the general population. What a lot of that probably has to do with is, to some degree, there is a higher rate of IV drug use in the black population, unfortunately. But I think a lot of it has to do with the healthcare disparities. Blacks have a higher rate of poverty, and we know that poverty lends itself to an increased rate of HIV. And we do see a higher rate among Hispanics, but not so much among Asians and even American Indians. Now, how do you get HIV? This is the percentage of cases that are spread by different ways. So in the United States, the plurality of cases are spread through male-male homosexual intercourse. Now, we say men who have sex with men. We don't say homosexual sex or gay sex, because not all these men identify as gay. As a matter of fact, some of these men have wives and they sleep with men on the side, and that can be a big problem because a lot of times it's sort of hookup with strangers and they don't know their HIV status. So that can be a huge problem, especially when you consider they're coming home to their wife and putting them at risk too. So that makes up the plurality. The next most common mode is IV drug use. And in this case, you may be sharing needles. That's a big problem because this is really the most risky behavior. You see that the plurality is men who have sex with men, but that's just because there's so many of them. IV drug use, there's not as many people using IV drugs, but it's much more risky. I mean, you're talking about sharing needles. You're taking somebody else's blood that you don't know and putting it into your own bloodstream. And so this is the most risky thing you can do, to the point where it makes up a quarter of the HIV transmissions in the US. Not negligible is heterosexual contact. That tends to be male to female heterosexual contact. So the man is spreading it to the woman. If you have a woman who has HIV and a man who's HIV negative, it's not as likely that she will spread it to him as much as he will spread it to her if he has HIV and she doesn't. And that really goes down to why does the gay population have a higher rate of spreading HIV? And the reason is because it's easier for men to spread it to somebody else than for women to spread it to somebody else. And when you're talking about men who have sex with men, you're talking about somebody who can spread HIV, spreading it to somebody else who can also easily spread HIV. And so you can see how that becomes a problem. So I really want to stress this, and HIV is a very sensitive topic, and HIV is not a gay disease, and it's not that there's anything wrong with gay people. It's just that anatomically it lends itself to this. And if you talk about gay people, who has the lowest rate of spreading HIV? Lesbians. They have the lowest rate because it's very difficult for them to spread bodily fluids from one to the next. All right, now you look worldwide. And when people say HIV is a gay disease, they're really looking myopically because the vast majority of cases are spread by heterosexuals. And that is because in Africa you have a lot of, not so much IV drug use so much, but you have a lot of vertical transmission. And so you have a lot of heterosexual men who have HIV, and then they spread it to non-infected women. So worldwide, heterosexual intercourse is 73%. Homosexual intercourse is less than 1% worldwide. So some basics of HIV. It is spread parenterally by infected bodily fluids, usually sexual contact or IV drug use. Very rare nowadays is HIV spread by blood transfusions. It used to be the case. You saw a lot of HIV in hemophiliacs because they got a lot of blood transfusions. That's really not the case anymore. You can also see HIV being spread vertically from the mom to the fetus, but this is very rare in the United States today. You go to poorer countries where they don't have as good prenatal care, they don't have as much women on anti-retroviral therapy. Vertical transmission is a big problem out there, but not so much here. What does the HIV virus do? It targets CD4 cells. The proteins on the surface of HIV are specific to those CD4 cells. What do CD4 cells do? They're T cells that are responsible for defense against atypical bacteria, fungi, and parasites. And when you look at some of the AIDS-defining illnesses and the things that the opportunistic infections that happen with progressed HIV and AIDS, it's things that are caused by these things. So toxoplasmosis, a parasite, esophageal candidiasis, a fungus, TB, an atypical bacteria. Those are all AIDS-defining illnesses, and you'll see that as opportunistic infections in people who do have AIDS. HIV, microbiologically, is a retrovirus. What is a retrovirus? It takes its genome, which is RNA, and it converts it to DNA. It's a retrovirus with retro, backwards, because it's the backwards way that we do things. When we transcribe, we take our DNA, our genome, which is DNA, transcribe it to RNA, and then ultimately make proteins out of that. With the HIV being a retrovirus, it has an RNA genome, it converts that backwards into DNA, and then it takes that DNA and integrates it into the host genome. So the enzyme that converts RNA to DNA is an enzyme called reverse transcriptase, which is a major target of our antiretroviral drugs. And then that enzyme, which I already mentioned, called integrase, takes that and puts it into the DNA of the genome, so that that cell, that CD4 cell, can start manufacturing HIV viruses, which can then go out and infect other cells. That integrase enzyme is another target, a newer target of our antiretroviral drugs, and we'll talk about that in a little bit. Now, the natural progression of HIV from onset to symptoms is about 7 to 10 years. Back in the 1980s, when we didn't have any medications for HIV, these patients would get infected with HIV, and in 10 years they'd be dead. That is not the case anymore. Now that we have antiretroviral drugs, people are living very, very long lives with HIV and not even having necessarily any infections from it. And this is a really good thing. Now, we haven't gotten to the point where we can cure HIV, so we can't take a person who's HIV positive and make them HIV negative, but they're living much longer lives and much healthier lives than they used to. And it's almost gotten to the point where people aren't even afraid of HIV anymore, so they're not having protected sex. And you see this, this is a big problem for the gay community, is that they're finding that the younger guys they didn't live around with an HIV scare back in the 1980s, and they're not worried about HIV. And so that's kind of a problem from an epidemiologic public health perspective. A patient's proximate prognosis, as far as how well they're going to do, is based on their CD4 count. You don't have CD4 cells, you can't fight off infections, that's going to be a big problem for you. Their infectivity, however, is based on their viral load. And the CD4 count and viral load, they kind of have an inverse relationship, but the patient's ability to spread HIV is going to be based on how much HIV they have in their bodily fluids, and that's the viral load. And this is going to play a big role when we talk about the acute HIV infection. So who should get tested for HIV? Well, really, I should put this on the top here. Anyone who asks. A lot of times patients don't want to tell you what they're doing. Maybe it's drug use. Maybe it's a young man who is having sex with other men and really does not want to admit that. So anyone who asks to get tested for HIV, you should let them get tested for HIV. Okay? Anyone who asks. But the populations that we're concerned about are anyone who is engaging in unprotected vaginal, anal, or oral sex. Really, vaginal and anal. Oral is not a really efficient way to transmit HIV. But anyone who's engaging in unprotected sex with partners of unknown HIV status. So here we're really talking about people who are promiscuous. Men who have sex with men, just because of the high prevalence in that population and because of the very efficient means, unprotected anal intercourse, very efficient means of spreading HIV. Also, another population you need to consider is people who are in serodiscordant relationships. So somebody who's HIV negative, whose partner is HIV positive, be them homosexual or heterosexual, doesn't matter. You really want to, and this is where pre-exposure prophylaxis comes in, which I talk about in another section, but we're really concerned about these HIV negative partners, especially if the HIV positive partner is not taking their antiretroviral drugs or something like that. So that's another population. We always want to make sure we're following up these patients. Patients who use or have used IV drugs and needles for reasons I don't even need to explain. Patients who have recently been diagnosed with an STD. If you get one STD, it's possible, very possible, that you might get another. And so we want to test those patients. Pregnant women. Well, being pregnant doesn't raise your risk of HIV, but they did have sex to get pregnant. And just as part of standard prenatal care, because if they are pregnant, we want to reduce their risk of spreading it to their baby. We test all pregnant women. All pregnant women in the first trimester, we test them all for HIV, even if they don't have any other risk factors. Patients who have symptoms consistent with acute HIV syndrome, which we're going to talk about in a little bit, this, we always want to test them. This is a very, very difficult thing to pick up, but it looks a lot like mono. And in these patients, you want to be getting a sexual history on them. They may come in, they may have mono, but you want to get a sexual history on patients who come in looking like this. What do we do for diagnosis? Write this down. This is a big change from what we used to do. We used to get a blood test. We would get an ELISA. That would be our screening test. If that came back positive, we would get a Western blot, and the Western blot would be diagnostic. That's how it was when I studied for the USMLE, when I was in medical school. That's how it was when I wrote my senior thesis on HIV. Not anymore. A few years ago, they changed it. Now you get this one test, and it's called the HIV-1, HIV-2 antigen and antibody immunoassay. It's a single test. It's a blood test. And you may also hear this called the 4th generation antigen and antibody immunoassay. This is the test we get now to screen for HIV. If this comes back positive, it's considered a diagnosis of HIV. However, there's a couple other things we need to do. We need to get 2 separate tests, one looking for HIV-1 and one looking for HIV-2 antibodies. Now, most of the time, one of these are going to come back positive, or sometimes both will come back positive. Occasionally, very rarely, they'll both come back negative. And if they both come back negative, what you'll then do is get a test for HIV-1 RNA. They call it an HIV-1 nucleic amplification test, I think. But that is testing for HIV-1 RNA in the blood. And that will really confirm it. Now, if you get both of these, they both come back negative, and then you get the RNA and that comes back negative, then you're going to assume that your original test that it came back positive was in fact a false positive. And this comes from the CDC, and it tells you exactly that. If they come back with a positive 4th generation, then you get a differentiation, HIV-1 and HIV-2 antibodies. One of those will probably come back positive. If they both come back negative, then you get an RNA, and that tells you definitively if they have HIV or not. And I'll just add, HIV-1 is the majority of HIV cases. HIV-2 is a little bit rarer. HIV-2 tends to have a less severe course, naturally. So this is the natural progression of HIV. You can see this spike here, where this red here is the amount of RNA, otherwise the HIV copies, which each of the copies have RNA. You can see that there's a big spike right between 4 and 6 weeks, roughly. And this corresponds to the primary HIV syndrome. So the reason it spikes is because you have no immune response. It takes you some time to mount an immune response, but ultimately you do. And you mount an immune response, and the HIV RNA will drop down, and then you stay down there. And typically this is when we diagnose HIV and we start anti-retrovirals, and they stay with their HIV RNA count very low, they're undetectable, their CD4 count never really drops, and that's a really good thing. But back in the 1980s, when we couldn't treat this, invariably 7 to 10 years, and they would be in AIDS and they would die. So this is the clinical latent period that we keep people in nowadays. But back in the 1980s, it used to be that they would gradually progress to AIDS. They would get into as their CD4 count dropped, they would get into stage 2, where they would start to have mucocutaneous lesions, recurrent upper respiratory tract infections. Ultimately, that would get more severe. They'd get chronic diarrhea, tuberculosis, and then ultimately, when their CD4 count would drop below 200 down here, they would start to get opportunistic diseases and then ultimately die. So acute HIV syndrome. This is difficult. So this is really difficult. This occurs soon after infection, and it corresponds to that point where they have a rapid increase in their viral load count and a drop in their CD4 count. And this is often asymptomatic. And when it does have symptoms, it looks a lot like the flu or mono, some kind of viral illness that it's really not that bad. And so a lot of patients won't even come in. They might not even realize they have anything. When they do come in, though, it looks like mono. So they have fever. They just feel out of it. They have swollen lymph nodes. It's classic mono, right? And most of them who do come in like this do have mono. But occasionally, it's acute HIV syndrome. So when you have a patient who comes in and they look like they have mono, you need to get a sexual history. You need to get a sexual history because if they have a history, recent history within the last 4 or 5 weeks of unprotected sex, you need to get an HIV test because mono, you don't really treat it. HIV, you absolutely need to treat it. So HIV, if you have a patient coming in with this, yeah, okay, you'll get a mono test, but you're also going to get an HIV test. And if that comes back positive, then you know that this is an acute HIV syndrome, and you will treat that accordingly. You treat that with something called highly active anti-retroviral therapy, or HAART, H-A-A-R-T. And all that means is anti-retroviral therapy, which we'll talk about in a few slides. Please note that patients who have acute HIV syndrome, at that point, they are very, very infectious because they have not begun to mount an immune response yet. They're in the process of it, but they have a very high viral load count, and therefore they are very infectious. And this is a big problem because these patients, when they have acute HIV syndrome, most of them aren't diagnosed yet. And so it's at this point when they're particularly infectious. And if they don't know they have HIV and they're having unprotected sex with other people, they're going to spread it to somebody else. So how do we treat patients with HIV? When a patient is diagnosed with HIV, ideally you'd like to refer them to a multidisciplinary center where they can see a specialist. However, you should know as a primary that there's a baseline workup that they need. So when you diagnose a patient with HIV and it comes back positive, you need to get a CD4 count, you need to get a viral load count. So that was both of those things here, CD4, viral load. Oops. And then you need to get viral genotyping, and this is going to be helpful for you when you start to treat them. And usually this is going to be done by a specialist. But you'll want to have this because what this is going to do is it's going to tell you that particular HIV strand that this patient has, that unique strand, what's the resistance and susceptibility to these different medications that we can give them. You also want to get baseline testing for tuberculosis because if they are TB positive and it's latent, that will need to be treated because if they do go on to develop AIDS, ideally they don't, but if they do go on to progress with their HIV, that can reactivate. You want to get CMV. You want to test for other STDs. HIV is an STD, so you need to test them for other STDs that they may have, gonorrhea, chlamydia, syphilis, etc. You want to get a toxoplasma antibody. Again, toxoplasma can cause an opportunistic disease if this progresses. And then in women, you want to get a pap smear. Why? Because we know that having HIV raises the risk of cervical dysplasia. So you want to get a pap smear. Then you want to get blood tests. These are mostly for treatment purposes because some of the drugs that we give for HIV can cause disturbances. We want to make sure that their liver is okay. Because if their liver is not functioning well, then we need to think about different medications. And some of these patients may have Hep B or Hep C, and their liver function may be abnormal, even though they don't have symptoms yet. You want to get a BMP. Why do you get a BMP? Because you want to check their creatinine level. You want to make sure their kidneys are working okay, because a lot of the HIV drugs are excreted through the kidneys, and some of them, particularly one drug called tenofovir, can cause renal failure. So we'll talk about it, and you'll see how this is all going to come into play. A fasting lipid profile, very important because a lot of these drugs can disturb the lipid levels. So this is more to get a baseline level, see where they're at. Ophthalmologic exam, very important because HIV can cause retinopathies. So this is part of your baseline workup. You want to make sure that all patients who are newly diagnosed with HIV, that they get their vaccinations. Now, if they do happen to go on to develop AIDS, some vaccines you won't be able to give them. So it's ideal that they get all their vaccinations now. You want to follow up every 3 to 6 months, and then the treatment is HAART, so anti-retroviral therapy. And this, again, get your pencil out and write this down. This is brand new, or at least in the last couple of years. We now treat them with anti-retroviral drugs immediately upon diagnosis. We do not wait. So a few years ago, we used to wait until their CD4 count dropped below 350 or their viral load count got above 55,000. No more. We do not do that anymore. And that kind of makes it easier for us because we know if you have HIV, you get treated. We don't wait anymore. So this is the treatment. Antiretroviral therapy beginning upon diagnosis. And this is a change from 2013 when I gave you this lecture last time. So antiretroviral therapy is the mainstay of therapy in HIV. And there are some things that you'll need to know about antiretroviral therapy. Not small details, but some basic things about how you choose a regimen and some of the side effects of some of these drugs. You'll need to know that for the USMLE. But this is very complicated. There are lots of different drugs. Try not to get bogged down into too many of the details. I'm going to try to point out the things that you need to know. So as I said, before starting, you need to get HIV viral genotyping. That'll help you determine the most effective drugs. More so, it'll tell you what drugs you really don't want to use because that HIV strand is resistant to them. There are 6 classes of antiretroviral drugs that are currently used. 4 of them, though, are used more commonly. 2 of them are newer, and I think the reason they're not very commonly used is because they're not generic yet, and so they're very expensive. But I imagine in the future you're going to be seeing these more and more. Particularly this one is really good, this fusion inhibitor, enfivuretide, also known as Fusion. I've only ever seen it in one patient I've ever taken care of in my entire career. But you'll probably see these more and more as time goes on. So the first 2 are both reverse transcriptase inhibitors. Remember, that converts viral RNA to DNA. And these are the NRTIs and the NNRTIs. You want to pay particular attention here to the NRTIs because with all of your regimens for HIV, you are always going to have 2 NRTIs as part of your regimen, 2 of them. Okay, these include things like zidovudine. Zidovudine is a famous one because that was the very first medication that was approved for HIV way back in 1986, even before I was born. Another one that you see more and more commonly now, and I think it's even gotten to the point now where it's starting to eclipse zidovudine as the most common, is tenofovir and emtricitabine. Tenofovir and emtricitabine are used together as a drug called, now the name is escaping, Truvada. And that is used for pre-exposure prophylaxis. So these are the NRTIs. You always use 2 of them in a retroviral regimen, antiretroviral regimen. The other one is non-nucleoside reverse transcriptase inhibitors. The one I want to quickly draw your attention to here is efavirenz. It is the only one, to my knowledge, that is contraindicated in pregnancy. It's pregnancy class D, meaning avoided at all costs. The only time you use it is if you ultimately have to. You have no other choice. Your hands are tied. But that won't come up on the test. Efavirenz for the test, absolutely contraindicated in pregnancy. Protease inhibitors. Now, I want to draw your attention here. If you are a gunner 99th percentile, you probably know that there's a class of protease inhibitors that is used for hepatitis C. And in fact, hepatitis C, you use protease inhibitors. The thing is, it's a different kind of protease inhibitor. So the protease inhibitor that gets commonly used in hepatitis C is something called telaprevir. All of the hepatitis C protease inhibitors end in previr, P-R-E-V-I-R. On the other hand, the HIV protease inhibitors all end in navir, N-A-V-I-R. So indinavir, sequinavir, ritonavir. Ritonavir, to my knowledge, is not used ever by itself. What it's used as is it piggybacks onto these other ones, like indinavir and sequinavir, and it helps them work better. So it is a protease inhibitor, but it's used to augment the other protease inhibitors. Then there's these integrase strand transfer inhibitors, which work on integrase. These are raltegravir and dolutegravir. These are really good drugs as far as side effect profiles go. And then those other 2 classes, which you don't see that much. So how do you form an antiretroviral regimen? This will come up on the test very commonly. As a matter of fact, I think it was on my USMLE when I took it. It gives you a patient who has HIV, very obvious, tells you you need to treat them, and then it gives you 5 answer choices, each with 3 drugs. And you need to choose which one is the most appropriate regimen. And the one that it is the one that has 2 NRTIs. So one wrong answer choice might have 1 NRTI, an NNRTI, and a protease inhibitor. One might have 3 protease inhibitors. One might have 2 NNRTIs and a protease inhibitor. The right answer is always going to be the one that has 2 NRTIs and then at least one drug of another class. So you aren't going to use three NRTIs. You're not going to use three NRTIs and nothing else. You have to use at least two and then at least one drug of another class. So at least two NRTIs and at least one drug of another class, be it an NNRTI, a protease inhibitor, or an INSTI. So NRTIs, nucleoside reverse transcriptase inhibitors, they work by blocking reverse transcriptase as a competitive inhibitor. So it blocks it at the binding site so that what's supposed to go to that binding site can't go there. It's blocked. The ones that you will want to know are zidovudine, because it's historically the most commonly used, but unfortunately has a really bad side effect, myelosuppression. So it can cause anemia, it would be a normocytic anemia, it can cause leukopenia. So for that reason, we're trying to find better drugs. Tenofovir, you'll see this one more and more commonly along with emtricitabine because that's part of the PrEP regimen. Tenofovir is good, but the big problem with tenofovir is that it can cause renal failure. It can cause anything from acute renal failure all the way to like Fanconi syndrome. So lots of different renal issues that it can cause. So you want to avoid this pretty much in anyone who has a creatinine clearance of less than 60. And this is why you get your BMP before you start your anti-retroviral regimen. Another one, very good drug called abacavir. And it's a good drug because if you have renal failure, abacavir is really good because it's not secreted really through the kidneys, it's secreted through the liver. The big problem with abacavir, the big limitation, is that you can get a really bad hypersensitivity reaction that can actually be fatal. And so if we ever give abacavir, we need to get a test before we give it, and that's an HLA B5701 test that will tell you if this patient's likely to have this hypersensitivity reaction. Obviously, if they do, you need to stop. I don't think that this test will come up on the USMLE, but what you do need to know for the USMLE is abacavir can cause a hypersensitivity reaction. Didanosine, zalcitabine, and stavudine, you do see them, but we're trying to use them less because of these possible side effects. And these side effects, this peripheral neuropathy and pancreatitis, they are linked to how long you're using it. So the longer you use didanosine, the longer you use stavudine, the more likely you are to develop peripheral neuropathy. And then didanosine and zalcitabine can cause pancreatitis too. Lamivudine and emtricitabine, very good side effect profile. And then this also you need to know for the USMLE, so write this down too. All NRTIs can cause lactic acidosis as a potential side effect. So the NRTIs, they also block reverse transcriptase, but they do it allosterically. They bind somewhere else on the enzyme and render it ineffective. So the NNRTIs, the one you want to know is efavirenz, and I already talked about it. You got the reason you want to know about this one is that you have to avoid this in pregnancy. As a matter of fact, women who, if you do need to put them on efavirenz, you want to make sure A, they're not pregnant, and B, that if you do put them on it, that they are on birth control. Okay, the protease inhibitors. So what is protease? Protease is an enzyme that kind of gives the HIV virion a haircut and makes it mature so that it can go off and infect your other cells. If protease isn't working, the HIV virion never really becomes mature and it can't effectively invade your other cells. So that's why we target this. The general adverse effect is something called lipodystrophy or liporedistribution. And this can happen from any kind of HIV medication, to my knowledge, but it's the protease inhibitors that do it the worst. The protease inhibitors can also cause lipid disturbances, so it can cause you to have like a high LDL. And so those are the two major adverse effects from protease inhibitors, and that goes for all of the protease inhibitors. And remember, all of the HIV protease inhibitors end in navir: ritonavir, indinavir, nafinavir, sequinavir, imprenavir, lopinavir, and atazanavir, I think it's pronounced that way. I've never seen that one. So that's what I want to draw your attention to is the lipodystrophy and the lipid disturbances. And then minor detail that ritonavir you don't use alone, you piggyback it onto these other ones, it helps them work better. This is liporedistribution. So what do you know about this guy? So look at his face. He looks, if you were to just look at him from the chest up, you see he really doesn't have a whole lot of fat along his neck. He looks really gaunt and thin. But then look at him from the neck down. He looks like an obese guy. I mean, he's got a big beer belly like my dad. You would think if you look from here down, you'd think this guy's like 250 pounds. But if you look at him from here up, you'd think maybe he's 150 pounds. So what's happening is that fat is distributing in different places. So he's losing weight in the cheeks, but he's gaining it and in the face, but he's gaining it in the belly. And this is liporedistribution, and this is a side effect of antiretroviral drugs, in particular the protease inhibitors. Okay, these integrase strand transfer inhibitors, these are relatively new. They came out in this decade. They block the enzyme HIV integrase, which is that enzyme that takes the HIV DNA that the reverse transcriptase just made, and they take that, and they cut it, and it puts it into the CD4 cell genome. If you can't do that, you can't integrate the HIV genome into the host cell genome, and you can't make more HIV virions. So this is a great place to target. It's very specific to HIV, and so it causes fewer adverse effects than the other antiretrovirals. So these include raltegravir, dolutegravir, elvitegravir. These are the INSTIs. So the regimen, as I mentioned, it's 2 NRTIs plus 1 or 2 drugs of another class. But you always have to have 2 NRTIs and then something else. This combination of therapy is known as highly active antiretroviral therapy, or HAART, but you may see it just written as ART, antiretroviral therapy. You always have to have this kind of regimen. Okay? You never will choose a regimen that has 1 NRTI and 2 other drugs. It always has to have at least 2 NRTIs and at least 1 drug of another class. The goal is that within a month, when you check the patient again, their viral load count should be cut in half. Ideally, with time, after several months, their viral load count should become undetectable. And then, of course, the CD4 count should rise as the viral load count goes down. You want to monitor these patients for HIV metabolic syndrome. One of the problems that can come from antiretroviral therapy is HIV metabolic syndrome, and all that is a disturbance in their lipid panels. So you're going to be getting lipid panels on these patients with HIV regularly. This is an example of these regimens. So note that you always have 2 NRTIs at least, and you always have at least 1 drug of another class. So you can have 2 NRTIs and efavirenz, an NRTI. You can have 2 NRTIs and a protease inhibitor. A lot of times we add on ritonavir to another protease inhibitor. You can have 2 NRTIs and an INSTI, like raltegravir. Or you may use 3 NRTIs. You can do that as long as you're using at least 1 drug of another class. All right. So what about in pregnancy? So specifically to pregnancy, there has been some changes. So part of those changes are based on the fact that now we put all patients who have HIV on antiretroviral therapy. Now it used to be that you may have a lot of patients who get pregnant, they have HIV, but they're not on antiretroviral drugs yet. And so we would need to start antiretroviral drugs for them because we want to minimize their viral load so they don't transmit the virus to their baby. But nowadays, it's gotten a little bit easier because a lot of these patients now are already on antiretroviral drugs. And so for the most part, we can just continue their current regimen. If they're on efavirenz, we may try to change it. And we may try to put them on something else, at least for the first trimester. But ideally, women who are on efavirenz should be on contraception and not getting pregnant. But if they are on efavirenz, we try to change that at least in the first trimester. If we have to put them on it, we try to hold off to the second or third trimester. It is pregnancy class D, meaning if you can find a better drug, use it. And there are better drugs. If her viral load is less than 1,000, and that's a relatively low viral load, then it's perfectly safe and recommended that she have a vaginal delivery, provided that she can have a vaginal delivery. As long as there's no issues like shoulder dystocia or stuff like that, then we can do a vaginal delivery. Otherwise, if she's above 1,000, need to do a C-section. When that baby is born, the baby needs to be on zydavidine for 4 to 6 weeks, and that's usually the most they need, is 6 weeks. And they need to be monitored for up to until 18 months. Now, when does the baby need to be on more drugs than just zydavidine? They need to be on more drugs than just zydavidine. They need to be on a triple regimen if mom has a high viral load count when she gives birth. And the reason for that is because that baby was probably exposed to a heck of a lot more HIV in utero. Or we give the 3-drug regimen to baby if mom was not on her own 3-drug regimen. She wasn't on antiretroviral therapy when she was pregnant. Okay, so if mom has a high viral load count, or if mom was not taking antiretrovirals when she was pregnant. And then this goes without saying, gotta avoid breastfeeding. The only time breastfeeding is appropriate is in resource-limited countries in the developing world where you really don't have much of a choice. But in the US, we have formula. We're a relatively rich country. Avoid breastfeeding. Formula, way better for the baby when mom has HIV. Okay, this is one more thing I want to talk about, post-exposure prophylaxis. So what happens if you have an HIV-positive patient, you're giving them an injection of something, and they jump, and now you just injected yourself, or you just stuck yourself with a needle, or you're doing surgery on a patient who has HIV, blood everywhere, you cut yourself, you're exposed to that blood. You want to avoid getting HIV, but you've already been exposed. So what we do is something called post-exposure prophylaxis. We're trying to prevent you from acquiring HIV after you've already been exposed to it. And so it used to be that we would put these patients on medication for 4 weeks, but we'd have to include zidovudine. No more. Now we put them on any highly active antiretroviral therapy for 4 weeks, but the preferred regimen is tenofovir and emtricitabine along with an INSTI, not a protease inhibitor, an INSTI. So tenofovir and emtricitabine both are NRTIs, and then an INSTI like raltegravir or dolutegravir. That's the preferred regimen. The only time we really use zidovudine now is if the patient can't take tenofovir. And the patients that can't take tenofovir are those, of course, with renal dysfunction and children under the age of 2. Tenofovir is not approved for children under the age of 2. So those are the patients we'll use zidovudine on. But the preferred regimen is tenofovir and emtricitabine along with an INSTI. That would be a 99th percentile question on the test, but there it is. So I just want to bring your attention to this. The people who need post-exposure prophylaxis, there needs to be 3 criteria that they fit. First of all, the fluid, whatever it was, needs to be exposed to their mucous membrane, so like their mouth or their eyes, or to non-intact skin, like you cut yourself or you get stuck by a needle and then that gets exposed to the fluids. But then that fluid's not just bodily fluids, high-risk bodily fluids. So if it's saliva or urine, there's not a lot of HIV in that. So you don't need to do post-exposure prophylaxis if an HIV-positive person spits on your, an open cut. But if it's blood, or if it's semen, or if it's, trying to think of something else, breast milk, then in that case, that counts as a high-risk bodily fluid. And then, of course, it needs to be an HIV-positive person. So all 3 of those need to be met. You also need to start this within 72 hours of exposure. So if you have a nurse come to you and say, well, last week I had an HIV-positive person, I got a needle stick. Well, if it was more than 72 hours ago, it's of no benefit to them to have prophylaxis. Because if they're going to get HIV, they're going to get HIV by that point. HIV testing should be done after you finish with their therapy, and then again at 3 months, or anytime they have symptoms of acute HIV infection, swollen lymph nodes, fever, sore throat, night sweats, etc., mono-looking stuff. You'll also want to do baseline testing for hepatitis B and hepatitis C because a lot of patients who have HIV carry hepatitis B or hepatitis C, so you want to do some testing for that too. Now, occasionally you'll have people who were exposed to HIV sexually. So you might have a woman who hooks up with a guy and they were drunk, they hooked up, and then she wakes up the next morning and he says, oh, by the way, I have HIV. I'm HIV positive, and they had unprotected sex. So she may come in, or maybe she got sexually assaulted, or he got sexually assaulted. Men get sexually assaulted too. If they have reason to believe they were exposed to HIV, then you will do post-exposure prophylaxis. In those cases, though, you want to test them for other STDs, because if they were exposed to somebody with HIV, they may have gotten exposed to other STDs. So you get an NAAT for gonorrhea and chlamydia, you get a syphilis antibody, and then if it's a woman, you may also test her for pregnancy. Okay? So just to recap, most patients with HIV are asymptomatic, but some present with a flu-like illness in the weeks following exposure. It looks like mono. Any patient you think has mono, HIV needs to be on your differential and vice versa. Therefore, you want to get a sexual history. HIV-1 and HIV-2 antigen antibody immunoassay, single blood test, is the screening test for HIV. ELISA and Western blot, no more. It should be confirmed with HIV-1 and HIV-2 type-specific immunoassays. So this comes back positive, then you're going to get each of these and test for them. Usually one will come back positive. The screening should be performed at least 2 weeks after exposure to avoid a false negative. So if you have let's say you have a guy come in and he says, well, I had sex with a guy 2 days ago and he had HIV and we didn't use protection. Are you going to test him for HIV now? Absolutely not, because it's going to take time to build enough of enough viral load for your test to come back positive. So you should wait at least 2 weeks. Actually, I'm sorry. If he came in 2 days afterwards, you would offer him post-exposure prophylaxis. Let's say he came in 5 days after. Okay, so then in that case, you're going to tell him wait until 2 weeks and then we'll test you, because otherwise you're going to get a false negative. Anti-retroviral therapy is the cornerstone of therapy for HIV. Regimens should include 2 NRTIs along with 1 or 2 drugs of another class. Adverse effects are diverse because you have a diverse set of medications. All NRTIs can cause lactic acidosis. Abacavir can cause a dangerous hypersensitivity. Protease inhibitors can cause a lipodystrophy. And lipids should be monitored every year due to HIV metabolic syndrome. And then all pregnant women should be on HAART during pregnancy. And that is a change from what it used to be. They should all be on at least 3 drugs, 2 being an NRTI, during pregnancy. And the baby should be on at least zidovudine for 4 to 6 weeks. If mom was not taking her HAART during pregnancy, or if mom had a high viral load count during pregnancy, then baby needs to be on HAART during that time. And also, very importantly, avoid efavirenz in pregnancy. And that's all I have for you. If you have any questions, write me a note below. Otherwise, I will see you next time.